Hypertension, it's often called the silent killer, and that's because for most people, it has no obvious symptoms. But inside the body, there's this constant, high-stakes battle being waged to keep everything in balance. So today, we're going to pull back the curtain on how your body controls this vital pressure and explore the really ingenious ways that medications can step in to help. So here's our game time for today. We're going to start with the absolute fundamentals of blood pressure. Then, we'll dig into the body's two main control systems. And finally, we'll see how pharmacologists have cleverly designed a whole toolkit of drugs to target these very pathways and bring that pressure back down into a healthy range. All right, so to really understand how to lower blood pressure, we first have to get a solid grip on what it actually is. And believe it or not, this entire complex, intricate system can be boiled down to one simple yet incredibly powerful equation. And here it is, that's the whole secret right there. Blood pressure is simply cardiac output, which is just the amount of blood your heart pumps out every minute, multiplied by systemic vascular resistance, which is basically how tight or relaxed your blood vessels are. Burn these two factors into your brain. Every single medication we're about to talk about is designed to tweak one or sometimes both of these variables. It's that fundamental. Okay, so how does the body actually control those two variables, cardiac output and vascular resistance? Well, it has this incredibly sophisticated internal control panel with two major systems working in concert to keep things right where they need to be. The easiest way to think about it is as a fast and a slow response system. The sympathetic nervous system is your rapid response team. It uses nerve signals for immediate second-by-second adjustments. And then you've got the renin-angiotensin-aldosterone system, or RAAS for short. Think of it as the long-term strategist, using hormones to manage pressure over hours and even days. So how does that fast system actually work? Well, you have these amazing pressure sensors called baroreceptors located in your major arteries. The second they detect a drop in pressure, they fire off signals that trigger the release of catecholamines, things like adrenaline. These hormones then have two main jobs. They hit beta-1 receptors on the heart, making it pump harder and faster to increase cardiac output. And at the same time, they hit alpha-1 receptors on blood vessels, causing them to squeeze tighter, which increases vascular resistance. Both actions work together to bring blood pressure right back up, instantly. Now for the slower hormonal system. It all starts in the kidneys. When they sense that blood pressure is low, they release an enzyme called renin. This kicks off a powerful chain reaction. Renin leads to the creation of a molecule called angiotensin 1. Then, another enzyme called ACE, that's angiotensin-converting enzyme, turns that into the real powerhouse of this whole system, angiotensin 2. This molecule is a serious double threat. First, it's a super potent vasoconstrictor, squeezing blood vessels and cranking up vascular resistance. And second, it signals the adrenal glands to release aldosterone, a hormone that tells the body to hang on to salt and water. This increases your total blood volume and, you guessed it, your cardiac output. So we've got these two incredible systems, one that's fast and driven by nerves, the other that's slower and hormonal. So now we can ask the big question. How can we use pharmacology to intervene? How can we design drugs that can precisely target these pathways and help turn down the pressure when it gets dangerously high? Our first set of pharmacological tools is going to target that fast-acting sympathetic nervous system we just talked about. We're going to focus on those nerve signals and how they affect the heart and the blood vessels. The drugs that do this are called adrenergic antagonists. Now, the name sounds a little complicated, but their job is actually really straightforward. Remember how those adrenaline-like substances activate alpha and beta receptors to raise blood pressure? Well, these drugs simply get in the way. They block those receptors so the signals just can't get through. And by blocking these specific receptors, we can get very precise effects. Alpha-1 blockers like doxazosin work by preventing blood vessels from constricting, which directly lowers that systemic vascular resistance. Beta-1 blockers like metoprolol work primarily on the heart, slowing it down and reducing its output. And here's a cool bonus. Beta blockers also happen to suppress that initial release of renin from the kidneys, so they actually give you a little bit of a head start on blocking the RAAS system too. Okay, another really effective strategy is to control the movement of calcium. Calcium is absolutely essential for muscle contraction, and that's true for both the heart muscle and the smooth muscle that lines all of our blood vessels. So the logic is simple. If you can limit how much calcium gets into those cells, you limit their ability to contract. Now, here's where it gets really interesting, because not all calcium channel blockers are the same. They're actually split into two major groups that have different targets. You have the dihydropyridines, like amlodipine. Think of these as specialists. They primarily target the calcium channels in your blood vessels, which makes them powerful vasodilators. Then you have the non-dihydropyridines, like verapamil. These are more versatile. They work on both the blood vessels and the heart muscle itself, so they also slow the heart rate down. And this crucial difference is exactly why they have such distinct side effect profiles. All right, let's shift our focus. We're moving away from the nerves and the heart and heading over to the kidneys and that powerful hormonal cascade, the RAAS pathway. The drugs we'll talk about now tackle blood pressure by controlling the body's fluid volume and by disrupting that angiotensin chain of command. One of the most straightforward ways to lower blood pressure is to just reduce the amount of fluid in the pipes. It makes perfect sense. If there's less total blood volume, then less blood is returning to the heart, and that directly decreases cardiac output. The drugs that do this are called diuretics. Now, all diuretics work by telling the kidneys to get rid of more sodium and water, but they do it with different levels of intensity. You've got your loop diuretics, which are the heavy hitters. They're very potent. Then you have the thiazides, which are the common workhorses, often a first choice for treatment. And finally, there are the potassium-sparing diuretics. They're a bit more gentle, and they have the added benefit of helping the body hang on to potassium, which is an important electrolyte that the other diuretics can sometimes deplete. And now we come to one of the most important and widely used groups of antihypertensives out there, the RAAS inhibitors. These drugs are really elegant because they offer multiple points of intervention within that renin-angiotensin-aldosterone system that we mapped out earlier. This table perfectly illustrates the three main strategies for shutting down that RAAS cascade. You can stop it right at the source by blocking renin production with renin inhibitors, or you can intervene in the middle with ACEI inhibitors, which prevent the conversion to that powerful angiotensin II molecule, or you can just wait until the very end and use ARBs, that's angiotensin receptor blockers, which let the body make angiotensin II, but they physically block it from attaching to its receptors and actually doing its damage. Okay, here's a crucial and fascinating detail about ACE inhibitors. They actually have a dual mechanism of action. The ACE enzyme doesn't just create the bad guy, angiotensin II, it's also responsible for breaking down a good guy called bradykinin, which is a substance that naturally dilates blood vessels. So when you block ACE, you get this amazing double benefit, less of the constrictor and more of the dilator. This unique effect, however, is also what's thought to cause their signature side effect, that persistent dry cough. Okay, we have covered a ton of ground, so let's take a moment to bring it all together and review the complete pharmacological toolkit that clinicians have ready to go for managing hypertension. So beyond our main categories, there are a few other specialized tools in the box. Direct vasodilators like hydralazine do exactly what their name says. They directly tell the smooth muscle in blood vessels to just relax. Nitrates, like sodium nitroprusside, give the body a source of nitric oxide, which is an incredibly potent natural vasodilator. That's why it's used in hypertensive emergencies. And others work in even more specific ways, like endothelin antagonists that are used for pulmonary hypertension, or dopamine agonists that trigger vasodilation through their own unique receptors. This final summary chart is your key takeaway. This is the one that brings it all home. It neatly maps every major drug class right back to the physiological system it targets and, most importantly, its primary effect on our core equation. You can clearly see how each class lowers blood pressure by either decreasing cardiac output, decreasing systemic vascular resistance, or in some cases, a little bit of both. Understanding all these intricate mechanisms, that's the science. But the true art of medicine is choosing the right tool from this entire toolkit for the right patient. It means looking at their other health conditions, considering potential side effects, and their unique physiology to make the perfect choice. And that is how we effectively treat the silent killer.